Should we get started? All right.
I was going to introduce you.
Oh, okay. All right. I was going to introduce you. Can we have everybody take their seats and move to the front? You don't have to actually move to the front. Oh, you're going to read this.
All right. Morning, everyone. Thanks for joining us for this session, which is going to be going through some challenging cases in sports medicine. I'm Michael Davies, one of the sports and shoulder surgeons at UCSF, and it's my pleasure to introduce our two esteemed panelists here for the day. So if you didn't miss our last session in this auditorium, first we have Dr. Brian Feeley. He's Chief of Sports Medicine at UCSF and specializes in shoulder and knee surgery. He's been at UCSF since 2008, earned his medical degree at Stanford, did his residency at UCLA and fellowship at the Hospital for Special Surgery. Dr. Feeley's definitely been my longest standing mentor in the department, and he has been awarded many times over again for his research and teaching efforts at UCSF. Next to him, we have Dr. Cindy Chang. And I don't know that there's anything that Dr. Chang hasn't done. She's a celebrated primary care sports medicine physician who's a UCSF professor emerita and does now more in her retirement from patient care than most of us do in our regular jobs. She currently serves as the chief medical officer for National Women's Soccer League and is on a variety of committees working to improve the physical and mental health of athletes at all levels. Previously, she won chief medical officer for Team USA at the London Olympics. And it would take a lot more time for me to go through all of her career accolades. So thank you to both Dr. Feeley and Dr. Chang for leading our panel today. All right. Let's see. Got a clicker here. Is this the one you're reading? There we go. Great. Big green button. Not the one that has tape over it. Okay. So these are our disclosures. So we'll jump right into our first case here. So the first case is a 17-year-old female who fell while snowboarding. She heard a snap somewhere around her ankle, had immediate pain, sat on her board to finish the run. She reported developing immediate swelling of her left ankle and some pain with weight bearing. She had not had a history of injuring the ankle before. She was taken down the slope and evaluated at the ski clinic, where she was told by the treating provider that her x-ray didn't show anything and she could weight bear as tolerated. So she returned to her school athletic trainer 1 week later at the end of winter break. And at that point, she was reporting and demonstrating on exam persistent tenderness and moderate swelling around her lateral malleolus. She didn't have any neurologic or sensory deficits or circulatory deficits. And overall, her ankle seemed stable on exam. So this was the only image that she kind of brought in from her initial evaluation on the ski slope, this lateral view of the ankle here. So before we kind of open up our discussion first to our panelists and then to the audience, if folks could take a moment and open up their app and take a look at this question. So after talking to your team physician, what would your team physician recommend here? A, you need to order another lateral ankle x-ray to evaluate a possible Shepherd's fracture, which is an acute fracture of the posterior process of the talus. B, you need to order another complete ankle series today, as subtle bony injuries may have been missed at the initial injury. C, place in a cam walker to immobilize the ankle and control her pain. And D, start physical therapy and follow up with her in 4 weeks to see if she's not progressing. So everyone take a moment and put in your answer. Great. So you can see there are kind of two dominating answers here. Most people say that we should get another complete ankle series today to look at other potential subtle bony injuries. Some folks feel we can put in a cam walker today and then recheck an x-ray a little bit later. So Dr. Chang and Dr. Feeley, what are your initial thoughts here in terms of your approach for someone who comes in with this imaging and with this story?
I send the patient to Dr. Chang.
So I'll start because I know less about ankles than I do about knees and shoulders. But I think anybody that comes in that has an ankle injury that isn't initially apparent on not great x-rays, I'm going to get a full set of x-rays. I think sometimes foot x-rays are helpful too, separate from getting just an ankle series. And then I want to check their knee too, because I sort of trust, or I mostly trust ski doctors to rule out acute things pretty darn well, because they're seeing them acutely injured and they see the same things over and over and over again. But I want to make sure that there's no distracting injury. So I'll make sure I will get new ankle films. I'll try to get a stress view to rule out a high ankle sprain. And then I will check their knee, mainly because I'm looking for something fun in the knee. And then I'll often get foot films as well.
Okay, so I think Dr. Feeley, great comments, Dr. Feeley. The clinical exam is really important, right? So the very first thing I would reiterate is if you don't see the x-rays, there's one view that this patient has on their phone, and that happens, right? They'll come in and they'll go, oh, I have this one view on my phone. You've got to be able to see all the views. The other thing is, even if they bring in a report, they don't even bring in a film, but they bring in a report, and the report says normal, but on your clinical exam, you suspect that there's a problem, you should repeat those x-rays. Because radiologists, for as good as they are, for those of you with the shoulder MRI type of lecture, they are not seeing the patient in front of you. And that's all they do, is they just look at films in a dark room, and maybe half the time they're half asleep, right? Just kidding, they're not. They're really good, but they're not seeing them clinically. They haven't taken the history, and you may write a really good history and like, please look at base of fifth metatarsal, or please look at lateral malleolus, and you get it back and it says ankle pain. Because you know what? Whatever you wrote wasn't transcribed by the person in the office. So the radiologist has no idea. So repeat those x-rays. And I agree, you have to look at the joint above, the joint below. You want to make sure there's no additional injury. So I think really the correct answer would be B.
I want to know why your snowboarder was on skis, though.
Oh, shit. Sorry.
So
there's a difference,
I just had surgery yesterday, so shut up. Don't give me grace.
But you're so much taller now.
So Dr. Chang, do you have kind of a go-to differential diagnosis for these ankle and foot injuries, in a skier or snowboarder in particular in this case, things that we don't want to miss, and really kind of the driving reasons for why to get more x-rays in this case?
Thank you. It's a great question. Yes, there is a differential diagnosis. However, snowboarders and skiers, they do not know how they fell. Most of the time, they have no idea. And it's like multiple tumbling. It's not like, I hurt my ankle. It's, I lost it. I slipped on the ice, frozen, whatever, and I just went. And they don't really know when they hurt that ankle, or they don't really know when they hurt their knee oftentimes. So yes, there's a differential, but I know where you're leading to, Michael, but I think that in this case, you have to really do a thorough exam. And if you come to the foot ankle, if you've been to the one, nicotomy, I already did one, you'll be able to do that. And based on where their swelling is, where they point to where their pain is, et cetera. But yes, I do have a differential.
All right. So these are the follow-up images, first x-rays, and then even some advanced imaging, a CT scan, to really kind of define the pattern of injury. And what we see here is a lateral process of the talus fracture. And so, these are commonly misdiagnoses because they can be very subtle to pick up on the initial x-rays. But if they're misdiagnosed, particularly for a large displaced fracture, they can lead to eventual subtalar osteoarthritis. So that's really the number one reason not to hesitate to repeat x-rays in these settings. Again, it's good to have a high clinical suspicion in snowboarders, but it really can happen with any sudden dorsiflexion and eversion injury. That's going to put a lot of stress on the lateral process of the talus. Small avulsions can typically be treated non-operatively with non-weight bearing for 4 to 6 weeks. However, if you have a patient who seems to have a larger, more comminuted or displaced fracture more than 2 millimeters, that's a good reason to refer to an orthopedic surgeon, as these can also be fixed surgically.
Hold on, I've got a question for Dr. Chang.
Yeah.
What is your differential for acute lateral sided ankle pain?
My differential for acute lateral sided ankle pain depends on the age. So if they're a younger athlete with open physes, I'm going to make sure they don't have a physeal injury. So that's where you need to know your Salter-Harris type of classifications. Of course, lateral ankle could be your ligamentous injuries. So Dr. Feeley had mentioned high ankle sprains as well, which is the syndesmosis type of injury, can create lateral ankle pain as well. You can have a lateral malleolus fracture as well. You can have a fifth metatarsal fracture as well. This is called the lateral, this is the talus fracture that we just demonstrated. It's got a name, it's snowboarder's ankle fracture, and it, Wisconsin, I believe, was where it was first, named. Did I miss anything else?
Anterior
Cuboid,
process of the calcaneus.
Anterior process of the calcaneus, spring ligament. I feel like this is a test question, Dr. Feeley.
Yeah, I think the other things I think about is perineal subluxation.
Oh, yeah.
Right.
Right.
And then just, I sprained my ankle, and you kind of glossed over it, but the most common thing you still see is a sprained ankle, and the severity is important. But what I look for that I don't want to miss, I don't mind missing a sprained ankle necessarily. Like, it's hard to miss; they're tender there, but I don't want to miss this or a high ankle sprain, because a high ankle sprain has long-term implications in how they're going to function. So I will get stress views on them if my athlete has something that isn't quite adding up, and they come back and they haven't gotten stress views when they went to the ED or urgent care. I will repeat stress X-rays on these patients.
Yeah, we could talk about how to do that too later. Stress views are hard.
Any comments or thoughts from our audience on this case?
If we go back really one slide too quickly, Dr. Davies, the posterior process fracture, you probably see this all the time, or you get a report that says os trigonum. So the os trigonum is a large posterior process where you can, I think you can see it on the screen. It is basically ossification body. It just didn't fuse. And that is a normal thing, although you can have pain there because there's a cartilaginous connection there, and you can actually injure that cartilaginous connection. But an acute fracture of a large posterior process of the talus is called a shepherd's fracture. And that's what it looks like it could be. And there's an example of it on you're at the right side of the screen. So that's what that is. If you're unfamiliar with that, that's what that is. Yeah.
Can you point to that on that? This one is easy to see, but the other one for me.
So this is the acute. This is like CT scan, right? So here, that's more of an os trigonum, where it's just a separate piece of the posterior process of the talus.
Got it.
Okay.
Okay. So you're not seeing this.
No. Not seeing that here. But this is an acute. This is a shepherd's fracture, and that is a os trigonum. Yeah. And then this is the really easy to see, on that side of the room, but really subtle. Here it is, right here. Right there.
Okay.
I don't think I'm about to run after my surgery, but here it is here. Right? It's really subtle, right? It's right there, and there's the correlation on CT scan. Okay.
Where is it on the middle screen? I'm just kidding.
All right, questions from our audience? Yes, sir.
From your perspective, would it be wrong to boot them and wait 2 weeks to get x-rays? Or, because I suspect a fracture already, even though the skin got mixed thing, but boot them and send them to the doctor, right?
Yeah, I think that's the answer. Boot them and send them to someone who can get those repeat x-rays. Yeah. Yes, sir.
What was it about this case that made you, it seemed like a week after she's got swelling, everything's stable. What was it that made you suspicious? Is it just because she was a snowboarder?
Snowboarder, persistent pain and swelling in that region.
Yeah, children don't swell. Like we swell. I swell. Cindy probably swells. Children don't have swelling unless it's abnormal.
Yes.
Is there any other mechanism besides snowboarding that you would worry about causing this fracture?
Yeah, so anything where you're any inversion type of injury, or eversion. So like the dorsiflexion, like basketball is common, but we see it most in snowboarders, honestly. Because of that, there's definitely so much more trauma impact.
Yeah.
Sorry. I've seen it in somebody I've seen one soccer and then one in basketball in high school athletes that they came down and stepped on the outside or stepped on their foot on somebody else, and then they were diagnosed as ankle sprains because it kind of sounds like an ankle sprain, but the mechanism isn't quite right. But it's like lateral sided pain, but they're not swollen in quite the right areas. It's typically an ankle sprain starts in the front and then works around the back, and they're like, it's like the opposite. They're like, wait a second, you're tender in the back and inferior, but not in the front. And so it's like, it's not quite an ankle sprain. And in both those patients, it was from a, large jump and landing funny, but the mechanism, the way they describe it, will sound like an ankle sprain.
Just include it in your differential.
Yeah.
This is why we're talking about these unusual, but not so unusual.
And there is sort of a higher energy, more dramatic injury mechanism version of these talus fractures that has kind of a funny name, the aviator astragalus. But basically this was named for pilots of small planes who, when they crashed their plane, their foot would be very severely dorsiflexed and everted, which is like the most dramatic version of this injury. That's usually a talar neck fracture. But that was one of the original names of this injury pattern. All right, so we're going to move on to our second case here. So now we have a 22-year-old club beach volleyball player who presents with low back pain as well as some spasming for 9 months. Her symptoms are intermittent. They're worse with spiking, with sleeping prone, and with walking long distances. She describes back pain extending down the posterior thighs, and does report a history of some low back pain growing up and playing indoor volleyball and lacrosse. She has, on exam, bilateral hamstring as well as rectus femoris tightness and pain with passive extension of her right hip when prone, as well as with active back extension. She's tender at the L5-S1 level and does have a positive straight leg raise with some symptoms that kind of go down to the plantar aspect, the bottom of her foot, but no weakness, and her reflexes are intact. So you saw her 6 months ago twice and recommended a rehab program, and it's now at the end of the season, and you asked for her to be evaluated with x-rays. So these are the x-rays that are obtained in your clinic. And before we kind of go to the question, do we want to comment on the x-rays at all here? Just kind of, maybe we'll go to the question and then come back to the x-rays. So keeping those images in mind, which of the following is the strongest reason to refer her to an orthopedic spine surgeon at this time? So although since the end of the season, she's been able to stop intermittent nighttime hydrocodone use, she now has continued to use the same dose of NSAIDs. B, she's been compliant with her rehab exercises for 3 months, but has no improvement in symptoms, even despite rest after the end of the season. C, she wants to try to play beach volleyball at a higher level after graduation. And D, selective nerve root blocks with corticosteroids 2 weeks ago provided only 50% relief. So some long answer choices. We'll let the audience kind of read that over and give us your thoughts, and then we'll discuss.
I wrote this. I know. Sorry.
That's why these are challenging cases in sports medicine.
No, they're not that hard.
Yeah.
You got them right.
Yeah. So it does seem like the majority of folks here kind of coming to the same conclusion that we did, which is that she's tried rehab, and even with rest, she continues to have the same pain. So that's a pretty strong indication to refer to an orthopedic specialist at this time. All right. So let's go to her follow-up imaging. So she was referred to an orthopedic surgeon and obtained...
Actually, I'm going to back up. How do you tell a patient to rest? Because I'm sure this comes up a lot, because if you tell me to rest, I'm not going to run today because I already ran this morning.
Right. It was a great question. So yesterday, the previous slide talked about all these options, right? the most important thing is knowing the informed consent part of this. Right. And so the whole rest is knowing what rest means to Dr. Feeley, knowing what rest means to this patient. And in this particular patient, it would be like, what do you mean you rested after the season? That's what you have to say. She could say, I've rested. I'm not any better. I'm still doing my rehab. But her rest would mean I'm not training 5 days a week with my club volleyball team anymore, but I'm still playing 3 days a week at Ocean Beach. Right? And so you've got to get a concept for what that means. So Dr. Feeley rests on the couch watching the Niners play versus, taking a run, which is not his usual run, but he feels like that's his relative rest. So you have to inquire about that.
So what do you mean when you say rest for something like this? Like, if she went and played volleyball just for fun, is that rest?
Oh yeah. So sorry, I didn't get what you were saying. So when someone said, if I were to say to someone, rest, I avoid hyperextension, avoid the positions and the things that make your symptoms worse. That's what I would focus on. So I would say, when you do your rehab program, are you having any pain when you do it? I would have them continue that rehab program. That's okay. I'm meaning rest from harmful activities or activities that create pain.
Yeah, and I'm just going to follow up on that. They were two separate questions, so you did good. I think this comes up a lot with throwers. It's like throwers will say, yeah, I rested. I didn't pitch in as many games as I thought I was going to, or I only threw in the back with my parents for about an hour a day, but I didn't pitch in both leagues. And I think it's important to define that rest and then define that success and failure with them as that's not what we mean by rest. And I usually will say, if a professional athlete rest, if Steph Curry is resting his ankle, he's in a boot and he's not running, and they're like, oh, so that's rest. So I try to bump it up to the level above them so they understand this is a normal thing that athletes have to do, is actually rest, except for me.
Great. So I want to go back to the X-ray imaging here and just kind of highlight, the important things that we're looking for on these lateral extension and flexion views of the spine. I guess I'll walk over to this side to point them out. These are lateral views with the patient kind of standing to the side, and these are obviously the vertebral bodies. This is the L5. This is the L5 vertebral body right here and the S1 vertebral body. And what we really notice here, especially in extension, but really you can appreciate it in the flexion views here as well, is there's anterior subluxation of this vertebral body, the L5 on the S1. And then the more subtle finding here, which will be less subtle on the advanced imaging, the CT and the MRI, is this fracture through the pars intraarticularis. So that's part of the sort of posterior vertebral column, and that is sort of what's contributing to this anterior subluxation. So this patient has spondylolisthesis, which we commonly see in kind of some of our younger athletes, particularly volleyball players, rowers, any other groups of athletes that you have a high suspicion for this type
gymnasts, dancers. Yeah.
So here we have the MRI and CT scan. On that image in the middle there, that's kind of the sagittal view of the CT scan, and you can really appreciate that fracture through the pars intraarticularis, which is part of the sort of defining pathomechanism here. And so just some important take-home points related to the diagnosis and treatment of spondylolisthesis. This is diagnosed, it's sort of classified based on the degree of that anterior slippage of the vertebral body, but the degree of slippage doesn't necessarily predict the need for surgery. So this is where it's really important to see, how symptomatic patients actually are. CT is the most sensitive study to diagnose, and I guess I don't really need this anymore. Up here. To diagnose and delineate the anatomy of the pars defect. And MRI is very important if there are any sort of neurologic symptoms present, because then you need to be thinking more about potential associated spinal cord pathology as well as nerve root involvement. Non-operative treatment includes physical therapy and bracing, which again can be helpful depending on the acuity of injury as well as the severity of symptoms, and oral anti-inflammatories. Occasionally, selective nerve root blocks can be helpful, and then activity modification is always something that's very easy to try early on. And you want to avoid the chronic use of opioids for pain control and really get to kind of the underlying problem and determine whether or not folks have been successful or have failed non-surgical management.
Really quickly, and then we'll take your questions. I would say if you look at the history of this 22-year-old, she talked about having back pain when she was younger, athlete, playing indoor volleyball, playing lacrosse, etc. And what I would say is, please feel comfortable ordering an MRI or evaluating for spondylolisthesis, an acute stress fracture, acute injury, and if they have any pain in extension, right, and they're reporting that, we want to make sure we catch that and we treat it appropriately, because if you don't, then it becomes a non-union perhaps, and then it proceeds to spondylolisthesis. Now there's also congenital as well, which we won't get into, but if it's an acute thing and they have back pain, again, as Dr. Feeley said, kids playing sports should not have back pain. And if they do, they're either, it's an overuse thing, they're doing too much, or they have pathology that's happening. So don't sit on that.
Great. And just to kind of review the terminology one more time, because these are pretty complicated sounding diagnoses. So a spondylolisthesis specifically refers to just that fracture through that pars intraarticularis that we pointed out on the imaging without any anterior subluxation of the vertebral bodies. Once you have that sliding forward of the vertebral bodies on one another, that's considered a spondylolisthesis, which is what we see in this case. And then the most severe form, which we don't have pictured here, when the vertebral body completely kind of falls off anteriorly, is called a spondyloloptosis. So hopefully you don't ever encounter that. But,
Right.
Questions from the group on this case before moving on?
I just wanted to know, thinking about this case of being a 22-year-old female athlete with the issue of osteoporosis, eating disorder, I know it's mainly dealing with a stress fracture, but what are your thoughts of evaluating that condition with this particular injury?
Great point. And again, this particular case is an older injury that's now started into the slippage. So who knows when it started, but at any time if you were the first time you saw her or any of adolescents, you definitely have to ask about bone health. And, we know about building healthy bone. It happens in the adolescent years early on. And you've got to make sure that you've asked those questions about disordered eating patterns. They've had a previous history of stress fractures. What are their menses like? And again, stress fractures can happen in males as well. And so that's the red S. And so you have to look at those components as well, because they can also have disordered eating patterns, and they can also have nutritional deficiencies, which can lead to poor or suboptimal bone health. Thank you for that question.
I'm going to ask you a question. Does the radicular symptoms, does that change your management? Like pain versus pain plus radiculopathy? Does that change rest versus surgical consideration versus injections?
It depends on how much it's impacting. Why do you keep asking me? I'm sorry. It depends on how much it's impacting.
I don't know.
Impacting quality of life and their ability to function. So certainly if there's determined weakness associated with it, if there's radicular pain, then there's irritation of the nerve root. And if you stabilize the spine through rehab, you can help with that. But if you need to make sure that you determine and check and see if there's any associated weakness with that. And if that doesn't improve despite pain improvement or despite more stability, that is a reason to look at surgery, possibly.
No, I don't like talking in that. I'll just talk
But you-
loud.
But
Is that okay?
That's okay.
Okay. I hate talking in that. What about if their pain can't be changed, like with any movement, and the pain is just always there? They're doing their therapy, you reposition them, everything, but that pain is always there. Is that an indication for surgical option more so than
So I would look at pain and function. There's a lot. So if function is impacted because of the pain, because there's a lot of people that have pain, but it doesn't impair their function. Because everyone's perception of pain is different, right? We all know this. So if the pain is impairing their function, then yes, that would be a reason to refer.
Okay.
Yeah. But if you've done all the strength testing as a athletic trainer, PT, or whatever, and their strength is good and they're still continuing to have the pain, and you've tried some other aspects of pain modulation or other types of things, and they haven't been able to change that pain, then yes. But just know that intervention doesn't 100% mean that they're not going to have pain. We know this. But you just have to inform your patients. Yeah.
Great. So we'll move on to another case here. We have about 10 minutes left. We'll see if we get through one or two more cases here. So now we have a 16-year-old male high school running back who's tackled during a game and feels immediate pain near his right medial clavicle and chest. He's initially short of breath, but he recovers somewhat, but he notices that he's not able to really move his shoulder at all without pain. So on his sideline exam, again, he's painful anytime you try to range his shoulder. He does have some tenderness to palpation at the medial clavicle and at his right SC joint without clear deformity, and he's non-tender to palpation at his acromioclavicular joint. So painful around the sternoclavicular area. And
Really quick, how many of you guys have covered a football game? Yeah. So is their exam good? Yeah, it's highly variable, right? You've got people that are like screaming on the ground with a cramp, and people who want to go back in with their leg 3 feet behind them. So I always take the exam for these things. I don't believe the players. I try to believe my exam more than anything else. And I always assume that the severity of what I see at the moment is going to be worse 5 minutes down the line.
so having said that, are you going to let this kid go back into the game based on this?
Are they good?
He's good, but he can't really move his shoulder.
Yeah, fine. Yeah, just turn left. No, this person doesn't go back in unless they have full range of motion. They're non-tender. And then what I usually do on the sideline is I'll put them through, like if they're feeling decent, like let's say they have an AC joint or something that feels a little bit tender, I will then have them go through even a couple mock plays, because sometimes all it takes is like they feel fine and then somebody else kind of just taps them here for like a clavicle fracture and like, nope, I can't play, that hurts. And I think they're okay at that, but when in doubt, if I'm covering high school football, they're staying on the sideline.
Yeah. So in this case, this player was in significant pain, could not go back in. And so Dr. Feeley referred them to the ER, and this was the x-ray that they got.
Wait, is this my patient?
Mm-hmm.
Okay. All right. Did I let him go back in?
This was the x-ray that they got in the ER. So we'll come back to this in just a moment, but we're going to open. Actually, everyone take a really good look at the chest x-ray here. I'll kind of leave this up for 30 seconds.
I know, right?
Okay, I know. I realize 30 seconds is actually way too long. So what is the appropriate follow-up imaging for this patient? Would you get a Zanka view x-ray, a clavicle x-ray? Would you go to a CT scan? Would you get an MRI? Or would you do an ultrasound? All right, so we're getting some of our answers in. So we can see people are sort of hedging between a clavicle x-ray versus a CT scan in this case. And, to be honest, I don't think a clavicle x-ray would necessarily be wrong, except for the fact that you can see the clavicles here pretty well, including the medial clavicle where this player has pain, and it doesn't look like there's a fracture there. So, what's on your differential for this patient, Dr. Feeley?
For this guy, I think
I would be worried about some sort of SC subluxation or dislocation. I'd be worried about a bruise. I'd be worried about his AC joint, because sometimes you can have pain kind of somewhat medially, but then in the end, I'm worried they will ultimately end up having an AC joint. I'm worried about like some sort of neck strain as well. But most likely, the thing that I'm worried about on the sideline when I'm covering, if they have anything where they're tender in the middle part of their body, I'm worried about a posterior SC dislocation.
Yeah. And so, the study that is most appropriate for working up a posterior SC dislocation, because these can be really hard to see on the plain X-ray, is to get a CT scan. So it's Dr. Chang?
Yeah, if you're, I don't think any of you guys, but if you're in a rural area, or you're in an area where it's really hard to get a CT scan right away, or there's a transport to get to it, the view is a serendipity view, is what you can do to see more of an axial view of the proximal SC joints. It's called a serendipity view. And you can actually be able to see more of an anterior posterior displacement on those at times.
Yeah,
But
we got that.
This X-ray that I showed here is actually the serendipity view. And so even here, it's a little bit hard to see. But if you notice that there's an asymmetry between the SC joints,
okay.
What you can notice here is on the right side compared to the left, that medial clavicle seems like it's sitting a little bit lower in an X-ray that otherwise doesn't look like there's sort of a rotational asymmetry. That is one kind of subtle sign on the X-ray that may cue you into an SC joint dislocation. Typically, the finding, I think, on the serendipity view is if one side looks asymmetrically lower and that's the symptomatic side, you worry more about a posterior dislocation. If it looks like it's sitting up higher than the other side, you think more about an anterior dislocation. But these, if there's any rotational, if the X-ray is not a perfect view, then rotational asymmetry can throw that off, and that's why it's better to get the CT scan, just to kind of then clearly see that, yes, this is a posteriorly dislocated SC joint.
So to be clear, for this guy, he seemed somewhat painful. He couldn't go back in. But our level of suspicion for this was only mild to moderate. So these things you can see walk into your clinic on a Monday or Tuesday, and you can see them come in a couple weeks later where they say, I haven't felt great. I've had a little bit of shortness of breath. Something feels funny here and it's a little bit swollen. I think I have a bad bruise. So these are not always caught acutely. And if I had to be totally honest, if it weren't for the fact that we had a resident on the sideline that was like, I think this is what he has, there was a chance he could have ended up just not going back to play, but being observed for a few days. So it's nice to have an earthquake and we're not in Eureka. It's okay. It's nice to have that ability to transfer patients. And again, when in doubt, if you're covering something or you see something that just doesn't look right when they come into clinic, I would jump right to the advanced imaging because it does change your management.
Localized swelling and clicking as well. They may come in and go, something's clicking. So.
Yeah, and so just to throw one other twist on this, one other very equivalent injury to a dislocation of the SC joint is a medial clavicle physeal fracture. So this is relevant to younger patients because the medial clavicular physis is actually the last growth plate to close. It sometimes closes as late as age 25. And so what can happen is instead of that dislocation actually being through the SC joint itself, it can be through that medial clavicular physis, which ended up being the case in this patient because he was a high school football player on the younger side. As far as SC dislocations go, anterior displacement is more common than posterior displacement, but posterior displacement is definitely scarier because you have all those vital structures right behind your clavicle and SC joint medially. And so treatment in this case is to consider a closed reduction in the OR versus an open reduction under general anesthesia. And when you're dealing, with a posterior dislocation, you always want to have, you want to know where your thoracic surgery colleagues are because you're working in very close proximity to the major mediastinal structures.
How do you reduce a posterior?
Yeah, so it's been described basically putting a towel clip, sort of piercing the skin, and then making sure you're staying on bone and getting that medial clavicle, and then basically pulling it out. It's even just thinking about doing that kind of right there, sort of anxiety provoking. So in this case, we ended up doing an open reduction because you're just staring right at the bone. You can reduce it in a little bit more of a controlled fashion. Any other questions from the group? We have just a couple minutes left, so we can kind of, yes, sir.
Taking it a step further on this injury with the shortness of breath that was mentioned, could this injury cause a pneumothorax?
Yes.
So not so much a pneumothorax, but we do sometimes think of compression of the trachea or bronchus, basically your mediastinal structures. It can even compress the aorta in some cases. So that's really kind of the scary part. Unfortunately, that was very transient for this player.
A pneumomediastinum, so you'd want to get a lateral chest X-ray if you were worried about that. But anyway, this last one's really good. Do you want to go through it real quick?
Sure. So last case, just a couple minutes left here. We have a 26-year-old active competitive soccer and basketball athlete who's playing kind of high-level rec leagues, who presents with an initial telehealth visit. So while playing soccer, he notes that he extended and planted his right leg to kind of keep the ball in bounds with the medial aspect of his foot, and his opponent kicked the ball hard against his foot. So try to picture that. He can't recall if his knee was fully extended or straight, but did have immediate pain in his right knee and couldn't continue playing. And the next day also reported some ankle pain. So I think he might have actually provided this diagram to Dr. Chang in terms of how he injured his knee.
My son. That's why you only hear from your kids when they're injured.
All right. So keeping this story in mind, the following important questions should be asked to help you narrow the differential diagnosis, except, number one, A, where is your pain located? B, were you playing on turf or natural grass field? C, have you injured that knee before? D, is your knee swollen inside the joint? E, does your knee shift and or feel unstable? So which question won't help you narrow your differential? Really getting into some tricky questions here, Dr. Chang.
I know, I'm sorry.
I disagree with B.
Oh, no, there's no evidence on this. No, there is.
Great. So kind of the distractor answer choice in there, I believe, was intended to be B. Whether it's turf or grass shouldn't really have any bearing here on the injury mechanism for the knee. So just let that kind of go back.
Next time you submit a case.
So this was the physical exam via telehealth. So there was no obvious effusion or soft tissue swelling seen, no bruising seen. With knee range of motion when the patient was seated, he indicated pain posteriorly in the right knee with end range knee extension as well as with flexion. During a double leg stance and then a double leg squat, he had vague discomfort of the posterior right knee. With a single leg stance and a single leg squat, there was more pain posteriorly in the right knee. And with a double leg stance and initiation of right knee flexion, there was pain posteriorly in the right knee. When he was asked to push on specific areas around the right knee, including lateral and medial hamstrings, couldn't really localize the pain. When he was asked to remove shoes and socks to evaluate the ankle, he had pain in the posterior right knee when removing the left shoe with the right foot. So that's kind of, that's a key exam.
So this is all stuff you can do virtually, right? Everything that was demonstrated on here. So differential diagnosis based on this?
Yeah, who hasn't looked at the last slide wants to give a shot at what they think is going on here?
Did you charge your son for this telehealth visit?
Jeez. I continue to pay for him. All right, we can just go on. But it is.
So this is how a popliteus strain would present. So these can be acute injuries or an overuse injury. In the acute setting, this would come from forced external rotation of the tibia on a partially flexed knee, falling onto the extended knee, or forced hyperextension. Now, the important thing that I want to mention there is this is kind of a spectrum of injury, which can go from muscle strain all the way to completely blowing out the posterolateral corner of your knee. So this is basically like a subtle posterolateral corner injury of the knee. In the chronic setting, this can be noted with increasing stride length, changing gait, and more hill running. And, this was a telehealth visit, but definitely an in-person exam would be recommended because popliteus injuries can be associated with other ligamentous injuries of the posterolateral corner, as well as more severe multi-leg injuries. So, I think an isolated popliteus strain like this is probably a pretty rare presentation, right? Because the most commonly, our posterolateral corner injuries actually show up in conjunction with other ligaments.
Our orthopedic surgeons see the big trauma ones. There's no question about it. And people who do sports medicine who see acute knee injuries. But I do think this sees us more than we see it. I really do. Posterior knee pain, vague. It'll usually get better. But for someone who's trying, I have seen so many athletes with a mild strain, mild to moderate, which has been missed. And these are people that are trying to get back to running their, playing their sport. I had someone steeplechase runner with this injury who was unable to return back to running. And this was her diagnosis. Is Nina in here? Nina treated her, helped me treat her. But it's a wide range. So this is why we submitted this case, is because I do think that someone that comes in with posterior knee pain, just be familiar with it. Be familiar that this is, because you can rehab this and get this better. It's better than just rest. And if you just do hamstring strengthening, et cetera, you just have to address it to be able to get them back to their activity sooner. But I do think the mild, moderate ones, people hold on to it and they don't come in. So just recognize it when they come in.
Yes, sir.
Is this a fairly stressful, forceful injury? In other words, could somebody get this like walking down the stairs or something?
Only if they miss a step and they go into hyperextension on the step, yes. So it can be a forced hyperextension. It can be, just basically going from jogging to starting to do fartleks or sprinting or overuse type of stuff. Or a lot of people move to the Bay Area, Berkeley Hills or San Francisco, and they start to do more hill workouts, or they can strain their popliteus.
Yes, in the back there.
To what degree is this a clinical diagnosis versus how much energy this person gets?
I did not hear that. I'm so sorry.
To what degree is this a clinical diagnosis versus how much more advanced imaging do you need to kind of make this diagnosis?
I think it's a clinical diagnosis. So you guys all have the slide. So truly, some of the things, like trying to kick off your shoe, that mechanism is. And one of my last patients, he was basically he had a swinging door. It was a heavy swinging door. And so he'd have to go through it from the dining room to the kitchen. And every time he tried to open it, it would hurt the back of his knee. So just be familiar with it. I think it's a great diagnosis to make. Like once you make it, you're like, oh my God. And you show your patient, they're like, oh my God, I have no idea. And now I finally have a diagnosis.
Yeah.
What was the main physical exam finding that you see with this, other than posterior pain? You kind of differentiate between a hamstring and a high gastroc strain, but was it rotational pain with rotation?
Well, remember, this is a virtual visit that I did with him per se, but yeah, it's a rotational visit. Yeah. So if you know where the popliteus starts and ends, it's resisted kind of inversion when you're in extension.
Yes, question over there.
You said something about hamstrings for rehabbing. How would you counsel, like you were saying about running hills and stuff, like how would you counsel people to prevent this injury if it's not a traumatic injury?
The question was, how would you counsel people to avoid it if it's not so the key to prevent it from happening again?
Prevent it if it's a non-traumatic injury.
Sorry, the shaking throws me off every time. So I'm from Ohio. So preventing it if it's a non-traumatic injury. So the other thing, so that what you're trying to do is if you are managing it and you've diagnosed it and you want this person to prevent it from happening again, right? So you don't.
No, even if they've never had it happen.
So that's for any overuse injury, whatever we're talking about, right? So everything is going to be gradually increasing intensity, gradually, changing, don't start running hills right away, or you're going to alternate how much you do. So maybe every third day you incorporate some hill running, et cetera, et cetera. But it's all the principles about avoiding overuse injuries.
I guess I heard you say something about the hamstring, so I'm wondering, is injury associated with tight hamstring?
No, not necessarily. No. What I'm saying is, if you just treat it like it's a hamstring injury, you may not be able to help it get better faster.
Oh.
That's why understanding the differential diagnosis is best. Because most people would say, oh, posterior knee pain, it's your proximal calf or it's your hamstring, et cetera. But you can evaluate and test for those.
Well, thanks so much, everyone, for your participation. Really appreciate you joining in.